You're listening to Treating Blood Cancers, the LLS podcast series for professionals. We will be joined by cancer experts to discuss blood cancer diagnosis, treatment, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the LLS podcast series for healthcare professionals. I'm Dr. Ken Miller. I'm a medical oncologist, a hematologist, and an LLS volunteer. And I want to thank all of you for joining us on this episode. Today we'll be discussing a very interesting topic, I think, on so many different levels, which is Medicare options and their impact on patient care and costs, challenges and strategies with medication adherence, and how healthcare professionals can guide older adults through Medicare choices. We're delighted to be joined by Dr. Stacy Ducicina, who is a professor in the Department of Health Policy and the Ingram Professor of Cancer Research at Vanderbilt University School of Medicine. Stacy is a health services researcher focusing on the intersection between health policy, epidemiology, and economics related to prescription drugs. We're also going to be joined by Bethany Lilly, who's the Executive Director of Public Policy at the Leukemia and Lymphoma Society, where she leads policy analysis, development, and research on all areas of engagement for the Office of Public Policy. Stacy, Bethany, thanks for joining us.
Thanks so much for having me.
Thanks for having me.
So I have to say that, this is sort of the perfect time of year to be talking about a lot of this because it's very, very practical. I have to say, I'm a practicing oncologist, and these issues come up all the time. To be honest with you, I'm not, in general, don't feel equipped to guide people and patients of mine, and yet it's real. It's a real set of issues. Let me pose just a very broad question. If you would give us an overview of healthcare funding for older adults on Medicare and what some of the options are for them.
Absolutely. And you are not at all the only person who struggles with this particular set of information. Pretty much everybody struggles to understand what your options are and how to make those options better to cover the things you need when you're undergoing cancer care. But even just making a general good decision about health insurance is very difficult. So for most people, when they age into the Medicare program, they have three broad choices. One is traditional Medicare without supplemental coverage, which means basically that you're just getting the traditional benefits with no extra help to cover additional out-of-pocket costs. There's traditional Medicare plus supplemental coverage, so that might look like you enroll into a Medigap plan or that you have some sort of retiree benefit that helps to supplement your costs when you try to receive care. Or you can pick Medicare Advantage, and that's private plans that are offered as part of the Medicare benefit. So instead of going under the traditional government plan, traditional Medicare, you pick a private plan. And often those plans are offered to beneficiaries at lower cost, or they include additional benefits that people really find attractive, like dental, vision, and hearing benefits that are not part of the traditional Medicare program. So those are your three large buckets to choose from. But you're making a big decision when you make that decision of what to pick. And most people don't really recognize those things that they're trading off when they pick one versus the other. And I'll just give you one example. In traditional Medicare, you are responsible for paying 20% of your medical costs without an out-of-pocket limit. That's why a lot of people, when they enroll in traditional Medicare, will get a private plan to help cover those costs. But that costs you more money. So if you're a healthy person or you don't have very much income, you might decide to forego those plans, those extra costs. The really great thing about traditional Medicare is every doctor takes it. So you don't get stuck being told you can't see this particular doctor or this specialist you'd like to see. You can have confidence that your Medicare benefits will be accepted everywhere. For Medicare Advantage, on the other hand, you might have to pay less. There's an out-of-pocket maximum that limits how much you have to pay, which is huge financial protection for Medicare beneficiaries. And you get all those extra benefits I mentioned, the dental, the hearing, and the vision. but they have closed networks. So, what that means is that if you want to get care at a specialized center, you have to make sure it's in your Medicare Advantage network, or you have to pay out of pocket for those services, or you might not be able to get them. As you can imagine, this is very, very important for someone with cancer because we know that a lot of cancer services are received at specialized centers. So if they're not included in your Medicare Advantage plan, you could be missing out on some really important clinical services that may really help you.
All right. So I sort of thinking of two groups of people, and we're all patients at one time or another. The group of people that are healthy, but essentially have some risk of developing cancer. And then there's a group of people that I'm seeing as patients who have been diagnosed with cancer and then find out it's the fall and say, my insurance is not covering things well, my copays are very high, etc. How would you think through with them the choices to make in both situations?
This is an incredibly hard problem to solve once people are in Medicare and receiving care. So, one of the key issues is you have all of these different choices to make when you first enroll into Medicare. But let's say you're healthy when you're making that choice and you decide to pick the Medicare Advantage plan that covers your primary care doctor. You feel like it's a good plan, it's inexpensive for you. And then you find out later you get a cancer diagnosis, and then the doctors you'd really like to see and the health system you'd really like to be in is not in your network. So, what do? Well, this is where things are sticky because there are rules about how you can get coverage if you wanted to be in traditional Medicare and buy those supplemental plans that lower your out of pocket costs. So you pick a traditional Medicare plan, you have to decide to go into the Medigap plan within 6 months of your initial enrollment. And after that, your plan can deny you access to Medigap, or you could have to pay premiums that are so high that you can't afford them. So, in a way, that initial decision that you make is absolutely one of those hard to undo decisions. Often we find these problems for patients where it's like, oh, it's too high for them, or we're no longer in their network, and we want to think about helping them figure out how to navigate it. But the system is set up in a way that it's really hard to undo those decisions. There can be options. So, for example, maybe there's another Medicare Advantage plan that a person can enroll into that covers the health system or covers their drugs better. But often you have to wait until open enrollment periods in this case. So you can't just make that change because now you're facing a health issue and you need to have better coverage. You have to wait until these set periods of time where you're allowed to reassess your benefits. It's incredibly frustrating because no one really expects to get cancer and no one expects to have high costs. We all hope that we'll be able to age and live healthy lives. And when that happens to you and you find out that the benefits that you have don't do enough to protect you, it's very frustrating. And then navigating to find ways to improve your coverage isn't always possible.
Yeah, absolutely. On a day to day basis, it's a big issue. Let me get your sense because a lot of the drugs I'm prescribing now are oral and highly expensive. Let's say there's a drug that out of pocket completely would be 15,000 a month. What's the range of coverage with the three options you just talked about?
So, the bad news that has been in place for years is that all of the Medicare Part D plans that cover outpatient and self administered drugs have had very bad coverage for cancer drugs. They're very expensive drugs, and there are no plans that offer a generous benefit, no matter whether you picked Medicare Advantage or traditional Medicare. However, the Inflation Reduction Act that was passed in 2022 has started to limit what people will have to pay for those drugs in Medicare Part D. And this applies to all plans, no matter which type of Medicare plan you've enrolled into. And what that will do is that next year, anyone on Medicare Part D will not pay more than $2,000 annually out of pocket for their drugs. So it doesn't matter if you're on a drug that costs $20,000 a month total price. $10,000, $50,000, it doesn't matter. You'll only pay $2,000 out of pocket for your orally administered prescription drugs. That is going to be transformative for people with blood cancers and people with other high cost drugs,
Yeah,
because right now they're paying often more than $3,000 for the very first fill, just one
yeah,
fill,
yeah.
and $10,000 or more per year. So this is going to be a huge savings. The other thing that it's helpful for clinicians to be aware of is that in addition to that total cap on out of pocket spending, there will be this Medicare prescription payment plan that is also available, where someone filling a very expensive drug will be able to pay that balance off over the rest of the year. So that's available then starting in January for all Medicare beneficiaries on Part D. So when they go to fill the drug, they will indicate on their plan that they'd like to be in the prescription payment plan, and then that payment just gets broken up. So it's much more likely that people can afford to fill their prescriptions and to take their drugs as prescribed. It's going to be a huge financial relief.
So I have to say, I mean, that's great. That's big news. And it's actually coming pretty soon. So, all right. So, any Part D. So, someone who has traditional Medicare, let's say Part A and Part B, and does not have Part D is still going to have to pay actually out of pocket.
That's right. Most of the time, what we see is that for people who aren't in Part D right now, they often have an employer or retiree benefit or some other source of drug coverage that is considered to be as good as Medicare Part D. What we really want is that when people are eligible to enroll into the benefit, that they also enroll into Medicare Part D. And one of the goals is to keep premiums reasonable so that even if you're healthier, you have an incentive to enroll into that benefit so that you have the coverage when you need it. At this point, most Medicare enrollees are in Medicare Part D. So over time, we've seen just a growing interest in getting into that benefit. And part of that is based on employers maybe no longer offering these types of retiree benefits. So they just kind of automatically assume that you'll enroll into the Medicare benefit when you age into the program.
Got it. In terms of patient care and again, helping people, what are some of the reasons for why patients don't take their medicines? I'm sure some of it's financial, and what are some of the other things you've noted?
I mean, not taking medications as prescribed, either never filling them or not filling them consistently, can be for a whole lot of reasons that have nothing to do with cost. Sometimes it can be simple things like people feel really healthy. They feel well and they decide that they don't need to take the medicine. It could be that the medicine makes them feel bad. You have side effects and other issues. And in fact, often we see that side effects or patients just making a decision for themselves that they no longer want to pursue treatment, those are all reasons that people might not fill their medications, and I think are super important to make sure that that's an informed decision. It's what the patient wants and that their desires are met. In my work, I focus very strongly on how are people able to afford their medications, because what I would like to see is that everyone who wants to be taking this medication that is helping them can afford to do that. So my work focuses very much on that cost barrier piece, because I know that people will make really different decisions for themselves or their family about whether or not to take a drug. I want to make sure that if it's a good drug, if it helps them, that it's accessible and affordable to them.
I'm just reflecting now, but there's a sense when people are hospitalized that there's often not a cost to them, but vice versa. In the pharmacy setting, there clearly is. So it makes sense now that the decisions people make can be quite different.
Just to follow up on that, we've did some interviews with patients who were struggling to afford their medicines, and one of the first patients we talked to really emphasized was that for their prescription drugs, you have to pay up front to get the service. So you
Yes.
have to pay at the pharmacy to get your pills. There's no other way. If you go to the doctor's office, you're still paying for those visits, but you get billed later. So you can often get the services that you need and then it's added to a tab. And those costs could be high, but they're not preventing you from engaging with the system or getting the treatment that you need. And it really does make a big difference in how people interact. The other thing is that the clinician isn't right there, right? So your clinician tells you to go to the pharmacy, fill your drug. You go, the price is too high, you have this sticker shock, and you leave possibly without your medicine. We've done research that was actually supported by the Leukemia and Lymphoma Society that showed that 30% of people who were prescribed new cancer drugs that were covered on Medicare Part D, 30% never filled them.
Wow.
So we're talking about a ton of people who walk to that pharmacy counter, get that sticker shock, and leave without their drugs. And think about the burden of that to a person and their family. Their doctor just told them that they need this medicine and they can't afford to fill it. And now they're leaving, probably not wanting to leave the medication behind, but feeling like they have to because they have other real costs that are preventing them from filling.
Well, the way you're describing it, firstly describes how it is. And there must be with that a sense of worry, a sense of shame, all this whole variety of different feelings. I wanted to ask you, so from the practicing oncologist point of view, purchasing the drugs are very expensive. Reimbursement is essentially at cost, just a little bit above sometimes. Some of the practices have changed and it's white bagging or brown bagging, or firstly, maybe you could say a little bit about what those are and how will that affect cost for patients?
Yeah, so white bagging and brown bagging are highly confusing to most people, but I tend to think about it as white bagging is basically that the insurance company is supplying the drug for the clinicians to administer in the clinic. They're getting the drug to you, or they're just directly paying for the drug rather than the practice buying the drug and billing for it.
Yeah,
The brown bagging, I think, is perhaps more controversial in that it's asking the patient to go and fill the drug and then bring it in to have it administered, which I think rightly so. People bring up concerns about safety, like temperature controls and things like that, things that are legitimate concerns about the handling of medications. And also, it's kind of a hassle for the patient to be asked to go and fill these things and bring them to the clinic. Those sorts of issues, it's hard to say which is more problematic for the patient. To the extent that white bagging or brown bagging adds delays into patients being able to get timely care, that could be a real problem. I'm not sure how much of a difference it makes for what the patient pays. It can definitely lead practices to have lower revenue. So, if a practice is making money on that transaction when they buy and they bill the drug, they can no longer really look to that part of the infusion as a source of revenue. So instead, you're kind of limited to getting paid based on whatever administration fee gets covered by the payer that is the patient's primary insurance.
yeah, yeah. I mean, the flip side of that is, again, sometimes if the insurance doesn't pay, these are drugs that are $10,000 to purchase, and 10,000, it's just a lot of money.
Yeah, that is an excellent point. And I don't know of any research on that particular issue because often we are only looking at things like paid claims. So we're only seeing the ones
Right.
that eventually went through and don't really have insight into practice finances and to
Yeah.
what extent our practice is losing money or just getting outright denied.
Let me ask you about the role of the medical team in terms of educating older adults, advising older adults. And I want to ask you more than just the physician, but really the team. And what are some strategies to optimally help people?
I think one of the most important things is to ask people first about how things are going because you're often not able to know if they're filling their medications at the pharmacy, if they're able to afford those, if they're struggling to pay. You could have an open dialogue about how things are going as far as their ability to afford their medicines. It often is that people don't want to open that conversation up because they're worried they can't do much about it. But at least having the conversation can help you identify if there are some low hanging fruit opportunities to help the patient. One example is I often get coworkers and friends who ask me about when their parents have a hard time or their grandparents have a hard time affording their meds. And they'll say, "What can I do?" And there are some easy things like check to make sure that the medicine that your doctor has prescribed is the one covered by your plan's formulary. If it's not, is there another option that you can switch to? For Medicare beneficiaries, every year during open enrollment is an opportunity to shop to see if you're in the right plan for you. And most people don't do this, but you can save a ton of money if you shop plans each year to know, okay, based on the drugs I'm taking now, what's the lowest cost plan for me? So you can actually have them go into the Medicare Part D plan finder and see if there's a better option for the drugs that they're on. That is going to be super important starting next year and the year after. So if you know somebody who's 65 or older, you should encourage them to go and shop for their Part D plan on the Medicare Part D plan finder. That's an easy way, I think, to start addressing problems with affordability. There's also one other broad thing that you can do, which is to recommend that people talk to the SHIP counselor in their state. So, SHIP counselors are a nonpartisan independent group of people that are set up to advise people about their Medicare options. And every state should have one. That is an easy resource to point people to and help your patients to know like they're in the best plan for them. And especially if you know someone who is about to transition into Medicare, that group can provide really great advice to that patient about thinking through what hospitals do they want to have access to as they age, what networks are covered by different plan options, and what are the options for Medigap plans in their area.
Firstly, thank you because we're entering the season and I want to, and I know my colleagues want to do a good job with this. What are some other resources besides SHIP?
Yeah, there are many. The ones that come first to mind are the Leukemia and Lymphoma Society, great resource, and American Cancer Society, also great resource for getting more information and starting to learn a bit more about health insurance options and resources for people with cancer in particular. Triage Cancer is another place that people may find very useful. And in addition, I'll put a plug in for CMS, Medicare's Part D plan finder. Again, it's a great time of year to start to look at plan options that are available. That'll be starting next month. If nothing else, it'll only take you a few minutes with the plan finder to go through and search based on the drugs that you use, and you could save a bundle.
So, again, as we enter this season, and I don't say to people, well, you should use this one or this one or this one. And I'm not expecting you to either because it's confusing, even using the resources. But very broadly, what are the categories of things that people should look at, particularly if they have cancer, to make these decisions? And how do you weigh those against cost?
So, if you're thinking about your initial Medicare plan decision and you have cancer and or you maybe have a history of cancer in your family and you're concerned about needing cancer care in your future, one of the things I think is most important to look at is where are the places where you would like to go for cancer care? Where are they covered? So that could be that in your area, maybe there's a Medicare Advantage plan that offers coverage for the health system that you would love to be in should you find yourself having to be treated for cancer. That might mean that you consider Medicare Advantage as a good option for you. They have a lot of attractive benefits, and often it's lower out of pocket costs for people on Medicare to pick that option. However, one important thing to know is that those networks that are set up are not permanent. So your cancer center that you'd like to be treated in can leave the Medicare Advantage network that you're part of, and that can leave you in a really big bind. So it is important to recognize that just because it's covered now doesn't mean it's covered forever. If you're really worried about where you go for treatment, let's say that there is just an outstanding system in your area that you'd like to be treated by, and there's not really other good options, you may really want to investigate staying in traditional Medicare and finding a Medigap plan that provides you with good coverage at the best possible price. This is where the SHIP counselors can be incredibly helpful because they're going to understand what's available in your area and they're going to have a better sense of the health systems that are covered by the Medicare Advantage plans. And they can also help you think about the quality ratings of those plans. What we don't know sometimes is they'll say that they have coverage of different services, but what does that really mean? So understanding how satisfied current customers are can be really useful. And the SHIP counselors can help you navigate those things as well.
So what I'm hearing is that the question is a complex one in terms of where you live and what systems are available and cost. But I'm also thinking out loud that, again, with the importance of cancer care and with the expense of cancer care, that sometimes spending a little bit more on an insurance plan for patients really pays off.
Yeah, absolutely. One example would be if you said, I want to enroll in traditional Medicare, so I know for sure I'm going to have access to all the cancer centers that I could possibly want to go to. But maybe you decide you don't want to pay for that extra premium cost of a Medigap plan. That's not a great decision for you because what ends up happening if you make that choice of traditional Medicare without supplemental coverage is that you're responsible for 20% of all medical spending. And in cancer care, that amount is unbelievably high.
Correct.
So, really, I think the choices for people are between Medicare with a Medigap plan, paying that extra premium, even if you don't need it right now, or Medicare Advantage, and really making sure that the centers that you want to be in are covered by these networks and hope that they stay that way.
So, Bethany, Stacy laid out very well and clearly a lot of the issues related to Medicare and healthcare, especially regarding blood cancers. But I'd like to hear some of your takeaways on what she had to say and also on the topic in general.
I totally agree that Stacy laid out everything so well. I did want to touch on a couple of specific details, and I think these are really the major takeaways this particular year about the new $2,000 out-of-pocket cap, because I imagine people are going to have a lot of questions about that. First, as Stacy said, this $2,000 out-of-pocket cap for drugs now exists. We in the Office of Public Policy and our advocates around the country advocated for years for this cap to be put in place, and we're incredibly excited that this year people will have this protection from the extreme costs sometimes of medication. Second, as Stacy said, the $2,000 cap can be spread out over the course of the year. $2,000 can be a lot of money for folks to pay up front. So instead, people can pay a little bit of that every month. We call the mechanism for this smoothing, and the official federal program that allows people to do this is called the Medicare Prescription Payment Plan. Patients should know that they have to opt in for this plan. It's incredibly important for people to pay attention to the mail they're getting from their Medicare plan right now, because those plans should be reaching out to let people know about this option if they have high drug costs. But even if the plan doesn't reach out, patients can call their health plan or they can check their health plan's website, and they should have options available to help folks sign up that way instead. And if someone is diagnosed later in the year, say they're prescribed a $10,000 a year drug in July, they can still opt into the payment plan if they want to spread those payments from August through December. But they may have to pay a little bit more each month because there are fewer months in the year than somebody who signed up in January. But it still adds up to $2,000 over the course of the year, and that new consumer protection going into this next plan year is going to be crucially important.
I want to clarify because it sounds like three things to keep in mind. The first is, do you have to opt in to have the $2,000 out of pocket?
No.
Okay, perfect. Number two, if you're interested in spreading out the cap, you do have to opt in.
Yes, that's correct.
Okay, perfect. And then the third thing, which I think is just terrific, is that if you didn't do it initially, you can do it later.
Yep, you can.
I mean, there is a kindness to that because typically it is a surprise. Someone doesn't expect to start the year and be faced with a $10,000 drug per month. So thank you. What can healthcare professionals like myself as an oncologist and my office staff, what can we do to help our patients with this?
That's an excellent question. And I think it's exactly things like this podcast because these changes are brand new. As I said, the $2,000 cap is brand new going to this next plan year. So patients will likely have a lot of questions about how does it work? Does this apply to me? Do I have to opt in? Is it automatic? And I think it's really important for healthcare professionals to stay up to date on what's going on and what these changes look like. Keep listening to podcasts like this one, but also the Centers for Medicare and Medicaid Services, CMS, has a website that's all about the $2,000 cap that you can check out. They also have a website specifically for that program that spreads out the costs over the course of the year. And they just added a new plain language video that might be really helpful if you're trying to explain this to patients. We are also going to be adding a lot more resources to the LLS website over the next couple of months as we see what questions folks have and try and answer those questions.
It comes to mind, if there is a cap for patients paying for these medications, who is paying for it? Is it Medicare or is it the Part A, Part B, the secondaries?
Excellent question. So prescription drugs are covered by Part D of the Medicare program. And so this cap is then being paid for out of the premiums that folks pay for their Part D plans. I will say, and this is, I think, important for patients to keep in mind, sometimes when you're getting oncology services, you'll be getting infused drugs, and those may actually be covered under Part B instead. And there isn't that cap for those drugs. I'll say that I think a lot of patients understand this problem very directly because they've seen the differences in their bills for Part B drugs versus Part D drugs. But if you're taking, for instance, oral chemo, that'll be under Part D. And so to answer your question, it's those Part D premiums that are paying for this entire thing.
Okay, terrific. What a good benefit. Because I have to say the cost, and I encounter this weekly when patients call me and say, geez, my copay is $2,300 per month, which is really not feasible. And is there another drug I can get? Well, often there's not. So terrific. So again, this is Dr. Ken Miller, and I have to say this has been a terrific discussion about a very timely and very important topic. I want to thank Dr. Stacy Ducicina, who's a professor at the Department of Health Policy at Vanderbilt University School of Medicine. I also want to thank Bethany Lilly, who's the Executive Director of Public Policy at the Leukemia and Lymphoma Society. Stacy, Bethany, thanks for being with us.
Thank you so much for having me.
Thank you so much for having me.
And I'd like to thank all of you for listening to this terrific episode. For a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources, please visit lls.org/CE. And for any questions or to refer a patient to LLS, including about the topic we just talked about with Medicare and insurance, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and support resources. LLS also provides other resources for patients, cancer survivors, and their families, including a series of podcasts that can be found at lls.org/support. I encourage you to sign up to receive notification of future podcast episodes by subscribing at treatingbloodcancers.org. And if you have any suggestions for future podcasts, please go to this episode page and click on the feedback button. We look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the LLS podcast series for professionals. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archives section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with LLS by following us on Twitter at LLSUSA and on Facebook at the Leukemia and Lymphoma Society, and access our professional continuing education activities by visiting lls.org/CE. Let's keep the conversation going. Until next time.